For most of human history, getting medicine into the body meant swallowing it, rubbing it on skin, or enduring a painful incision. If a patient couldn't keep food down, if a drug dissolved too slowly in the stomach, or if seconds mattered in blood loss, physicians had almost no options. The constraint wasn't a lack of drugs, it was the barrier of skin itself. By the early 19th century, doctors understood that opium could relieve pain and that certain plant extracts could stop infection, but oral doses were slow, unpredictable, and often vomited back up. Topical applications rarely penetrated deep tissue. Surgeons could cut into veins directly, but the procedure required restraint, caused infection, and wasted time in emergencies. The human body had evolved a waterproof, pathogen-resistant outer layer, and medicine had no reliable way to bypass it without causing more harm. The problem was mechanical as much as medical. A drug swallowed had to survive stomach acid, pass through intestinal walls, travel through the liver, and only then reach the bloodstream at diluted concentrations. In cases of severe pain, shock, or poisoning, that delay could mean the difference between recovery and death. Physicians needed a route that was faster, more direct, and more predictable. The challenge was finding a way to pierce skin without tearing tissue, introducing infection, or losing control of the dose. The first attempts to pierce skin deliberately came from a different problem entirely. In the 1600s, architects and engineers were fascinated by hydraulics, the science of moving fluids through pipes under pressure. Christopher Wren, better known for designing St. Paul's Cathedral in London, experimented with injecting wine and opium into the veins of dogs using a sharpened quill and a bladder as a reservoir. The animals survived some trials and died in others. Wren's goal wasn't therapeutic. He wanted to test whether substances could travel through blood. The equipment was crude, the method unreliable, and within a few decades, the experiments stopped. For the next 150 years, injection remained a laboratory curiosity rather than a clinical tool. Physicians still had no practical instrument. Quills split, bladders leaked. There was no way to control dose or pressure, and without an understanding of sterilization, infections killed more patients than the experiments helped. The missing piece wasn't just a sharper point, it was a system. A tube narrow enough to slip between muscle fibers, a reservoir that could hold a measured amount, and a plunger mechanism to deliver it smoothly. The turning point came in 1844 in Dublin. Francis Rynd, an Irish surgeon, was treating a woman with severe facial nerve pain that had not responded to oral morphine. Rynd took a trocar, a hollow metal tube used for draining abscesses, and sharpened one end to a fine point. He punctured the skin near the nerve, then used gravity to let a morphine solution drip through the tube into the tissue. The pain subsided. Rynd published his results in the Dublin Medical Press, describing the technique as a way to place medicine exactly where it was needed without waiting for digestion or absorption. He did not attach a syringe. He did not inject under pressure. But he had proven that a hollow needle could deliver a drug through intact skin and produce a rapid effect. Rynd's invention worked because it solved the access problem without requiring surgery. The trocar was thin enough to pass through skin cleanly, and the hollow bore allowed liquid to flow directly into tissue. Gravity provided the pressure, slow and steady, avoiding the trauma of forcing fluid through a wide opening. The method was immediately useful for localized pain relief, but it had limitations. Gravity was weak, doses were difficult to measure, and the technique required the patient to remain still for several minutes while the solution dripped in. Within a few years, other inventors began adding the missing components. Charles Pravaz, a French orthopedic surgeon, combined a hollow needle with a screw-driven syringe in 1853. His device was made of silver, heavy, and expensive, designed for injecting coagulants into aneurysms rather than everyday medicine. Around the same time, Alexander Wood in Edinburgh built a glass syringe with a finer needle and used it to inject morphine subcutaneously, under the skin rather than into veins. Wood believed the drug worked locally, near the injection site. He was wrong about the mechanism. Morphine travels through the bloodstream, but his tool worked. Patients felt relief within minutes instead of waiting an hour for a pill to dissolve. The mechanism that made hypodermic injection possible was a convergence of metallurgy, glassmaking, and fluid dynamics. The needle had to be thin enough to minimize tissue damage, but strong enough not to buckle under pressure. Early needles were hand-ground from steel wire, with the hollow bore created by wrapping metal around a fine mandrel and soldering the seam. The syringe barrel had to be transparent, so the physician could see the contents and measure the dose. Glass was fragile, but it could be boiled for sterilization once germ theory emerged in the 1860s. The plunger had to create a tight seal without leaking or sticking. Leather and cork gaskets were tried first. Rubber, vulcanized and resilient, eventually became standard. Each component had been developed for other purposes and then adapted. Hollow metal tubes were used in surgical drainage. Glass cylinders came from laboratory glassware. Rubber seals were borrowed from industrial machinery. The hypodermic syringe was not a single invention, but an assembly of existing technologies, combined in a way that finally made controlled injection practical. The breakthrough was recognizing that all three elements, needle, barrel, and plunger, had to work together as a closed system. Adoption was not immediate. Many physicians distrusted injection, associating it with the failed experiments of earlier centuries. Others worried about infections, especially before Joseph Lister published his antiseptic techniques in 1867. Patients feared the needle itself. Unlike a pill, injection was visible, invasive, and required a trained hand. But the clinical advantages were undeniable. Morphine injected subcutaneously took effect in minutes. Adrenaline injected during shock could restart a failing heart. Vaccines delivered by needle produced stronger immune responses than oral doses. By the 1880s, the hypodermic syringe had become standard equipment in hospitals across Europe and North America. The cost, however, was also becoming clear. Morphine addiction rates climbed steeply in the late 19th century, particularly among women treated for chronic pain, and soldiers given the drug during the American Civil War. The hypodermic needle made relief so immediate and so repeatable that dependency formed faster than with oral opium. Physicians initially believed that injecting morphine avoided addiction because it bypassed the digestive system. That assumption was wrong, and by the time the mistake was understood, thousands were already dependent. The same tool that gave medicine unprecedented speed and precision had also made one of its most dangerous substances easier to misuse. Another consequence emerged in the 20th century: the risk of disease transmission. Reusing needles without proper sterilization spread hepatitis, syphilis, and later HIV, particularly in settings where resources were scarce or hygiene protocols ignored. The invention of the disposable plastic syringe in the 1950s, mass-produced and designed to be used once, reduced but did not eliminate the problem. Today, needle stick injuries remain a significant occupational hazard for healthcare workers, and improper disposal of used sharps continues to pose public health risks in many parts of the world. There is a broader lesson embedded in the history of the hypodermic needle. It was not a single flash of genius, but a slow assembly of components: hollow metal, transparent glass, vulcanized rubber, germ theory, and mass production, each developed for other purposes and then adapted. Rynd's gravity drip became Pravaz's pressurized injector, which became Wood's subcutaneous syringe, which became the disposable plastic device now found in every clinic. The invention solved the problem of delivering medicine quickly and precisely, but it also required new systems to manage its risks: sterilization protocols, controlled substance laws, needle exchange programs, and occupational safety standards. The hypodermic needle changed not only how medicine enters the body, but also how society thinks about medical intervention. Before injection, treatment was largely passive. A patient swallowed a pill and waited. After injection, treatment became active, immediate, and often performed by a professional rather than self-administered. That shift created new roles for nurses and pharmacists, new regulations around who could possess needles and syringes, and new ethical questions about consent and bodily autonomy. The tool that solved the problem of skin as a barrier introduced a new problem: controlling access to the bloodstream itself. Today, more than 16 billion injections are administered globally each year. The hypodermic needle remains the fastest, most reliable way to deliver vaccines, antibiotics, insulin, and emergency drugs. It also remains one of the most tightly regulated medical tools, governed by laws that control who can possess it, how it must be disposed of, and what substances can pass through it. The barrier of skin, once an unsolvable problem, is now crossed billions of times a day. What changed wasn't just the tool. It was the recognition that bypassing a natural defense requires not only precision, but responsibility for everything that follows. Visual reconstructions are illustrative. Facts and interpretations are based on the sources listed in the description.